All right, good afternoon, everybody. Please note that for today's webinar, your microphones are muted, but feel free to use the chat function for any questions that you may have through the session. Please also note that for today's webinar, the recording and presentation will be distributed via email to all attendees after the webinar has concluded within 1 to 2 business days. And we'll just give a couple more seconds for those last remaining people to join in, and we'll get started. Awesome. Welcome, everybody, once again to today's On My Mind webinar hosted by the My Mind Collaborative Quality Initiative. We are so thrilled to have you all join us today. My name is Jason Robertson, and I will be your host for today's session. First, I'd like to announce that today's webinar is approved for 1 CME CEU credit. On screen, you will see the code and telephone number to text in order to receive credit today. You have 24 hours from the conclusion of the webinar in order to text that unique code to receive credit. The details for the CME CEU credit are in your meeting invite if you received that for you to reference, and it will also be displayed on screen at the conclusion of today's webinar. Before we get started, I also want to read a brief disclaimer to you. The views and opinions expressed in this webinar are those of the speaker or speakers and do not necessarily reflect the views of Blue Cross Blue Shield of Michigan or of Henry Ford Health. Now, it is my pleasure to introduce today's presenter, Larry Herren. Larry is a highly accomplished licensed master social worker with more than 35 years of professional experience. He currently serves as the leader at Community and Home Supports in Detroit, overseeing the Behavioral Health Division and supervising the agency's education department. In addition, Larry maintains a thriving private clinical practice through the Oakland Evidence-Based Psychotherapy Clinic. His specialties encompass a broad range of treatment areas, including substance use disorders, family therapy, and mental health, including depression, anxiety, stress management, grief, and loss. Larry has also served on the State of Michigan Licensing Board for Social Work, contributing to the professional standards and regulation of social work practices across the state. Today, he will be speaking on the unique challenges and effective strategies for engaging men in mental health treatment and suicide prevention. In the discussion, Larry will move beyond universal screenings to explore what comes next, focusing on practical, effective steps for intervention. Woven in, he will also share insights and personal reflections on how to recognize and overcome the specific barriers that men face. We'll plan for 45 minutes of presentation, followed by approximately 15 minutes for questions and answers today. Before we begin, just a couple reminders that microphones are all muted. Please use the chat function to submit your questions at any time during the presentation today, and Sarah, who is with us, will be administering those as well. Our MyMind team will be monitoring the chat and will assist in facilitating any Q&A at the conclusion of the event, or if it's relevant during the event, we will make sure that Larry gets the question right away. So with that, let's go ahead and get started. Larry, the floor is yours, sir.
Hey,
Jason, thank you so much.
Really quick. Sorry, Larry. Sorry, Larry. There's a couple people on the chat that said they couldn't see the slides or that it was a blank screen. I was wondering it might be good just to stop sharing and reshare just because I'm not sure that everybody can see it.
Oh,
Sorry
it's
about
better
that.
now. Oh, they're back. They said they can see it now.
Oh, okay. Great.
Okay,
Go ahead,
thank you for
Larry.
that, Sarah. Sorry,
Okay.
please chime in, anyone, if you can't. Larry, we're back to you. Thank you.
Thank you. And yeah, let me make sure. Here we go.
There you go.
Good afternoon, everyone. My name is Larry Herren, and as Jason said, I'm an LMSW social worker, and it is an absolute honor to be with you all today. I'll tell you two things about me right quick. I'm not very technologically sound, but this team here is amazing, and I appreciate it. The other thing is, I'll forewarn you that I'm addicted to metaphors, so I'll probably be using a few to make some comparisons and things. I want to say too, what a thrill it is for me to be here at Henry Ford and presenting for you today. This is kind of old home week for me. I spent about prior to my present position, some 23 years working at Health Alliance Plan. So every day we worked either directly or indirectly with Henry Ford Health Systems. And and I'm not exaggerating when I say that some of the most brilliant minds in healthcare, I'm privileged to say that I was privileged to work under and to learn from. Um, and I'd like to give a special shout out to one of those individuals, Dr. Kathy Frank. I'd like to offer my congratulations to her recent retirement. Dr. Frank certainly deserves it. She's just a stalwart in healthcare for sure, particularly behavioral healthcare here at Henry Ford. And also, I'd like to give a shout out and a heartfelt thanks to Dr. Doriana Espiritu. I've known Dr. Espiritu for many years, and I'd like to thank her for her invitation to present here today about this most important subject, men, masculinity, and suicide, what clinicians need to know. Um, Suicide is obviously a problem. It's something that we as clinicians understand is problematic, but sometimes maybe don't understand how it works for men and doesn't work for men in terms of getting involved in treatment and staying engaged. So that's what we're going to cover today. In fact, our agenda includes an introduction to men and masculinity and understanding the concepts of masculinity. There's various different definitions. We'll take a look at what the difference between masculinity and toxic masculinity might be, and how that latter uh, can be detrimental to a man's ability to get the treatment that they need. We'll take a look at exploring male suicide rates, the difference between men making attempts and killing themselves versus women, and the other just general statistics in the population. We'll also look at factors contributing to male suicide and barriers for men uh, entering into mental health treatment. And then finally, we'll take a look at what the literature is saying some of the best practice and interventions and treatment techniques are. Um, there's many, but we'll take a look at the five that we're going to go over in this particular presentation. So with that, let's move forward. And as also, let me just say too, as Jason noted, um, I think that learning works best when we learn together. So please, I hope that this presentation will kind of provoke some questions in your mind and or some discussion points. If you have some techniques or some experiences that could be helpful, please jot them down, ask questions, and we'll take a look at them. There's no wrong questions, and I say that loosely. I've said that before in presentations and thought, oh geez, maybe I should have put a boundary on that. But we'll take a chance. Go ahead, ask anything, and we'll do our best to answer it. And or again, if you have you have your own personal experiences, don't hesitate. We'll take a look at that, and we'll learn together. So men and masculinity. It's important to understand men and masculinity when addressing mental health. Clinicians need to understand how societal expectations shape men's experiences, core beliefs, behaviors, and willingness to seek help. There's a lot of contributions that societal expectations make and shape, and let's take a look at what some of those are. So, masculinity versus toxic masculinity. Um, what what is masculinity a bad thing? What do people think? Is you know a man thinking of himself in maleness necessarily bad? Um, to understand the definition of masculinity, let's consider these points, key points. Masculinity refers to traits, behaviors, and roles traditionally associated with being male. So if I said to you that it often includes characteristics like strength, assertiveness, independence, are those concepts bad? I would say not, right? I mean, I would assume that people would look at those traits and say, well, those are strengths. However, when they become extreme, that's when we get into trouble, right? it often includes in toxic masculinity, which is something that appears in research as well as pop culture, is generally having uh, three core ideas, and that includes toughness. Again, being tough isn't terrible. In fact, it can be a strength, but being physically strong to the point that you become emotionally callous or behaviorally aggressive, this is when it becomes toxic. Also, in the core ideas of toxic masculinity is anti-femininity. So, what does that mean exactly? Well, that men are taught that they should reject traditional feminine behaviors such as expressing vulnerable emotions and accepting help. Um, if it's accepting help about asking directions, I'm not one of those. I don't have time to get lost. I want directions. I don't think that takes away from my masculinity at all. But you know what? I got friends that refuse to ask directions. They just absolutely have to find it on their own. And then finally, power. Again, seeking leadership, seeking to be in leadership. That's not a bad thing. But when that power is internalized to mean power and status socially and financially, and thus in doing so, I will be able to demand people's respect and have it, that's more toxic. At CHS, at Community and Home Supports, which is right down the street here, we are a Detroit-based agency that assists homeless. And we we just recently had a agency-wide, actually, I think there was three agencies involved, leadership training. And interestingly, that leadership training was consisting of learning more in leadership how to be coaches. So the idea is that you coach your direct reports, that you give them responsibility to take their own leadership in various things. It's not an old style of bossing, it's more of a leadership and coaching kind of perspective. That's kind of a difference between how masculinity may appear and toxic masculinity may appear as it plays out in authority. Also, in toxic masculinity, there's the glorification of unhealthy habits. So, glorifying, for example, habits around self-care, deeming that you know, you get kind of risky. Self-care and medical attention, that it's only for women, and discouraging men from seeking doctors. A 2011 study, in fact, found that men who held the strongest belief about masculinity were only half as likely as men with more moderate beliefs about masculinity to get preventative health care. As practitioners, we understand preventative care medically can lead to death and or you know, basically anything that we catch early enough can usually be fixed, but if we wait too long, we're going to be in trouble. And that is the same in emotional care. So, and obviously suicide. So yeah, that's can be a very big risk. And also, toxic masculinity promotes the idea that real men treat their bodies like machines, need little sleep, work out even when they're injured, and push themselves to their physical limits. Research indicates that strong conformity to masculine norms foster risky behaviors like heavy drinking, tobacco, poor diet. Men who exhibit toxic masculinity tend to view these choices as normal. So, big difference between healthy masculinity and toxic masculinity, and how that then gets involved in men seeking the care that they need. With regard to cultural and societal contributions to how a man might define masculinity, I believe it's probably incorrectly assumed that race, ethnicity, religion, culture, social economic status, they can all contribute. And two, how the individual identifies himself within any of these categories significantly influences their perspectives and expectations they have for themselves and what a man is, what men are typically supposed to behave as. So, but also important to understand is the concept of in the concept of masculinity is that uh, that is changing across society and time periods. And we're seeing that, in fact, and how timelines play out in this. So historical perspectives, um, this is something to pay attention to in your clients that, for example, uh, how younger adults might see it. In fact, there is a 2024 Pew Research study that found Americans under 50 are more likely than those 50 and older to believe that men are who are caring, affectionate, soft-spoken, or open about emotions are undervalued by society. Younger adults under 50 are more inclined to see these traits and as underappreciated compared to older adults, indicating a generational shift in views on traditional masculinity and emotional expression in men. These findings are noted to align with other research showing younger men often feel pressure to be manly, but also increasingly values emotional openness, even if societal judgment remains. Um, I don't know if you could tell, but I'm in that over 50 group. Um, and it's it's kind of plays out in the clients that I've seen how generationally the definitions that they bring to therapy will definitely play into what they feel okay to talk about, what they feel okay to admit, what they grapple with. And and even if I bring that home to myself, the differences between um, back in the 70s when I was an adolescent versus today. Um, I'm a single dad. My son is 22. Um, and I have students, and I'm very pleased to have social work students. In fact, at CHS, we have an educational program where we run an internship for social work students. We have 13 students from 8 different universities that we're credentialed with this particular semester, and some of those students are in that younger generation. And to do this presentation, I've spoken to a few of them, and we we've kind of gone back and forth with the differences between what masculinity means. And it's been enlightening to say the least. It really has. Um, give you an example, um, how masculinity can sometimes be interpreted and presented and play out between the two generational gaps. Um, I I asked one of my students, Nick, who's played 4 years of football between Wayne State and Madonna University. Nick's a big guy, but he wasn't willing to paint his nails for his girlfriend. But he did mention that if she wanted to do it as a joke, he might consider it. My son, on the other hand, who is uh, pretty capable himself, he's a second-degree black belt in mixed martial arts. Um, he played 4 years of varsity lacrosse, played club at CMU, but you never hear it. He won't talk about it. And one of the kindest, most gentlest young men that you'd ever want to meet. And I remember he was about 18, 19 years old, and his girlfriend at the time, he hasn't done this since, but his girlfriend at the time, uh, he painted his nails to match hers. And I called him out. I admit it. I called him out. And I guess I'm thankful enough that I've raised him to have enough ego strength to say, Dad, my masculinity is not dependent on what color my nails are. Don't know if you've noticed, Dad, but she's really hot, and that's what she wants me to do, and I'm doing it. And he did, and he went out in public with him, even when she wasn't around. And so I was a little concerned. I asked my girlfriend at the time of what she thought of it. And, she told me, I think it's wonderful. I think that is the most wonderful thing. And I'm not surprised. He's just so caring, such a sweet young man. That's just wonderful. So I said to my girlfriend, who was of my generation, um, so you all right then if I paint my nails to match yours? And she said, hell no, it's not happening. No. So again, it just kind of it's interesting how generationally, things change and shift, and it truly has. which segues into the historical perspectives of how masculinity is viewed and plays out. And I've noted here, it's not my father's therapy. And in fact, as I looked at that and thought about it, it's not his era, nor is it mine. I've actually lived long enough to realize, and I think this is a good thing, therapy has changed quite a bit even since 30, 35 years ago when I was a new therapist. And the perspectives of therapy, what people thought about therapy, obviously the stigmatization of therapy that was going on then is not near as much as it was today. And it's softened, it's adjusted some. It's still out there, and I'd love to see the elimination of it completely. But the way that it's viewed is different. And so I think one of the main things in all of this that we need as practitioners and clinicians to remember is that the way masculinity is defined and reflected, presented, and demonstrated in people's lives, it's no longer so fixed. There's a diverse, just amongst society, just so many diverse ways that masculinity can present itself. And we as clinicians need to understand that it's not fixed. We need to meet our clients where they're at and to be accepting of where they're at to then help them to function through it. And whatever that means, right? To understand their story, their experiences, and how they've arrived at where they've arrived. So in that regard, when we can do that, I think that clients will feel less shamed, less judged, and more likely then to engage in treatment. And if not treatment, at least engage in discussion, which can lead to treatment. And that's what's important. So that's I think a huge message in all of this. And then as we move on to take a look at some of the statistics. As you can see here, I know that print is small and I hope you can see it, but male suicide rates are very, very different than women. Women will make more attempts, yet men are in number killing themselves more often. So death by suicide is occurring more in male population, even though less attempts are made. Why is that? What do people think? I asked this question the other day with a group that noted a few that I think are definitely in line, and that is that, and I see a lot of yes, absolutely, and we'll get to those lethal means. That's interesting that that so many comments are coming across that it's the lethality and lethalness of it, and that's accurate. We'll get to that in a minute. But also, I think something to note is that um, women are more likely to talk to one another about what they're feeling, about what they're thinking, about experience, processing it. That can help. That can actually help. I mean, communication is huge. Men are less likely to do that. Why? For the same reason they're less likely to get into treatment, right? It's like, well, they wouldn't understand. Well, I don't know. I'm not quite sure how to feel about it, let alone communicate it. I'm not quite sure what's going on with me. Nobody's going to understand. Screw it. Let me just kill myself here. I'm done. And they give up. And so, yes, communication is huge and can save a life. Also, um, there is, in fact, the lethal way that men are killing themselves. The literature, for example, estimates that in over 60% of suicide deaths among men, the method they used to kill themselves was with firearms. Let's be honest. You know, if you cut your wrist, you're it's definitely lethal. It's you can die, or if you overdose, you can definitely die. But you put a bullet in your head, in your throat, your mouth, even your chest, you're probably going to die. That's as lethal as it gets. And men are more likely to use guns. Every suicide prevention uh, presentation that I've ever been to, what the experts say is that people are more likely to use what they're most familiar with to kill themselves. So, in other words, if people are used to taking meds or pills, right, they're likely to do that. If people are used to being around knives, they're likely to do that. Men are used to being around guns. There's more gun ownership among men, probably twice as much as there are women. That's the number is actually growing among women, but men are usually the owner of guns and using them, and they're familiar with it, and that's what they tend to use. So that's the lethality. And while all age groups are significant, the suicide rates are also highest among men aged 75 plus. Why is that? What do people think? Um, what the literature states, and I would highly agree, is that suicide rates among 75 plus is because people are feeling socially isolated. And when you're feeling isolated, it definitely, yeah, lonely, no question. Um, Disconnected, start to question my purpose in life. Men absolutely want to make a purpose. Um, the loss of dignity, the loss of independence. Michelle, let me speak to the loss of independence from a personal perspective. I could use a lot of fancy literature and use some training that I've had or experts that I've spoken with. Uh, no one taught me more about being elderly than my mother, God rest her soul. I took care of her. She was 93 when she passed. I miss her dearly. She was amazing. And I will say, let me just preface this with that she died a very happy woman. But I can remember one day we were driving down the road. I don't remember where we were going or what the conversation was about, but it triggered a deeper conversation. And she just absolutely broke down in tears. I mean, sobbing. I thought I'd have to pull over to the side of the road. And I'm like, what's going on? And her her response was that she'd outlived her time. And I'm like, outlived your time? What does that mean? What do you mean? And she said, well, everybody's gone. My family, my parents have passed, my siblings, my cousins, which for her cousins were siblings, and good friends that she grew up with. And I kind of tried to take that back and said, well, mom, you have family, you have grandchildren, you have children, you have friends, you have people that love you. And she agreed. She said, you're right. And I value them greatly. But the people that I cut my teeth on with in life are gone. In my childhood, my adolescence, even my young adult years, everybody's gone. They're gone. I'm the only one left. I'm 89 years old and I'm all that's left. And she was grieving her, she was definitely grieving her youth. She was grieving that I was driving because she couldn't drive anymore. And when she lost her driver's license because of blindness, I'd seen her grieve less over loved ones than losing that driver's license. And I'm thankful to say that we were able to neutralize that with present day family. But you know what? Some people can't. Some people, it's not only losing that, but it's losing that, well, none of the, I don't live in my own home, which she did. I'm in an assisted living home and nobody comes to see me, or I don't have the connection that I want to everybody. I'm just sitting here waiting to die. Well, why wait? I mean, that's loneliness on steroids at that point. So yes, the elderly are very, very much at risk. And as that relates to men, I'm just going to say that I think men are typically of the opinion and self-worth that a lot has to do with what kind of purposeful differences I can make, what kind of purposeful differences and meaning I bring to the table. And when I don't feel like or think that I'm able to do that, that's a risk. That's a potential hazard for sure. So that's some of the statistics. Let's move on and take a look at factors and barriers to treatment. Um, as as I'm sure that the audience here can understand, a mental health diagnosis, particularly untreated, is a risk. Substance abuse is a risk. Um, what I've learned over the years and what others, colleagues and others, leaders in the healthcare division and industry have all stated and taught, right? That a diagnosis with substance abuse is like a diagnosis on steroids. So if you are depressed, if you're anxious, if you're psychotic, and you then add any kind of a mood altering substance to the table, you've now got that diagnosis on steroids. It just exacerbates it that much more. Now there's again, we're going to talk more about this further on down the slide, but you want to treat the diagnosis and the suicidal ideations kind of separately. You can treat them together to some point, but also separately. You want to make sure that the suicidal ideation gets warranted attention in and of itself. But when this diagnosis is exacerbated, so too probably is the ideation of suicide, and substance abuse only complicates it and exacerbates it that much more. And as I'm sure the docs can tell us, when you're taking psychotropic medications, which is supposed to help here, um, you use enough substance, those medications no longer are taking effect. I've got a client right now who was using marijuana every day. So I challenged him to, because in his diagnosis, I can't remember what the med was, if it was Lexapro or Seroquel. I can't remember exactly what he's taking, but he was noting that it doesn't seem to really be working. And I asked him, well, how much weed are you using? Pretty much daily at night. It helps me sleep. So we discussed that and we discussed, okay, so do you want to learn how to sleep without weed? Well, sure. And do you want to feel what you feel? Do you want to feel, for example, if you want to capture feeling happy, do you want to be able to feel that? Well, yeah. And I did a little graph for him about what weed is doing to his brain and the neurons firing and whatnot. And he bought into that. I think men tend to look at mechanics and things that are concrete, and we'll talk a little bit more about that in best practice treatments. But when they can kind of see that on paper and conceptualize it versus just subjective feelings out there, they buy in a lot faster. So he did. He tried to he's done a great job stopping the weed. I warned him that there probably is going to be a little withdrawal, and there is, and there has been. But I mean, he's just done just a phenomenal job and reported to me just a few days ago, last time I seen him, that in fact he's only used weed once in the last 10 days. And he said, and you know what? You were right on. He said, man, I'm starting to feel things I didn't even know I was feeling, and I feel happy. I think the meds are working. And there it is. So as I told him, that's not the first time that's been reported to me. It it tends to be the deal. So substance abuse can be a big contributing factor. Um, Relationship crisis, of course, can create more stress, more shaming, more internal shaming, particularly that people might feel, judgment, internal judgment too. Communication skills. What does communication skills have to do with this? Well, if if one is not communicating or able to communicate um, with efficiency, then the people that need to understand what's going on may not. And so um, it's important that we slow ourselves down and get ourselves down to, okay, what is my client saying here? And how can I help them to say it more effectively or more understandably? What do I need to do to understand what they're trying to say? And because communication skills are definitely important to helping us understand and even them understand what it is going on for them. And of course, economic stressors. If a man is of the opinion, and I think most are, that I need to be able to uh, provide for my family or provide for myself, or that somehow economic status is meaningful to how much of a man I am, and they're having stressors here, that can contribute to risk factors in shaming and judgment, but also stressors in general, right? When you're already stressed out and you have this internal stress going on, any of these things, relationship crises and economic stressors particularly, um, can only then will oftentimes contribute to falling deeper into that dark hole of depression and carrying out the suicidal thoughts and making attempts to kill yourself. So these are all factors contributing. Barriers to treatment include a lot of what we've been talking about. The stigma engaging in behavioral health treatment that often men will have in masculinity, particularly toxic masculinity. Fear of judgment. With my clients, I like to start with the judgment of themselves. When people are worried about how other people are judging them on any given issue, first thing I'll try to do is find out and understand, what's your thoughts about it? Well, I don't think I'm very good at this, or I felt like a loser on this for a long time, or, I never was able to please my dad about this, or I've felt abandoned in this regard here or there, right? So it's just natural. I'm thinking that other people are going to see me the same way. So again, ego strengths play into this quite a bit, or lack thereof. Cultural expectations of men. Again, the culture that we grow up in has a lot to do with it. That same student I mentioned that played football, we talked about how in both of our experiences, the athletes that we've known over the years that are playing a particular sport because it's what their dad wanted them to do. They didn't even like the sport, and they just were playing because they were trying to somehow capture the meaning of what it was to be a man. Um, Look, I love sports and I do play for the love of it. But there's a lot of men who don't. They're trying to compensate in some way, and through that, and that's again that's telling. Um, Perceptions of weakness. So again, if I have to go to treatment, it means I'm weak. And then there's also the flip side to that, the fear of the weakness. So, well, my gosh, if I start talking about this, it's going to open up a can. I want to be overwhelmed. I can barely deal with just the thought of it, let alone going in and opening it up. And that's why I try to tell clients that part of what I do is be a gatekeeper, and I kind of explain what that means, and assuring them that we're going to talk about more than than what you're able to talk about. I promise. We've got days, weeks, months to go. It doesn't have to happen all at one time, and I'll do my best to make sure it doesn't, so that you can leave out of here feeling better than you walked in. And in fact, early in my career, that's how I was taught. Don't ever open up a can you can't close in therapy. Don't ever open up something that you can't put a lid on for the next session, because when you do and they leave, now you've put them at risk. So it's really important that we are gatekeepers, and just how much and how and to what depth our clients are sharing at that time. And then of course, limited availability of male focused services. That's something that's again, um, we want to be a little bit more creative and understanding. And to that end, let me just say too that June is Male Mental Health Month. I'm really glad that we have a month now that's dedicated to helping males and the public in general realize that men need mental health too. So want to encourage that everybody get engaged in that in June, and of course every day. And then September is National Suicide Awareness Month, and that's for everybody. It's we'll talk more about Henry Ford's zero suicide model, but if we can eliminate suicide, well, we're doing great. That's truly what we should be striving to do. So I think it's clear that that talking about um, suicide ideations and thoughts are important and a clear first step in identifying if someone is at risk to kill themselves. And if we take a whole uh, body and mind approach to this, we have to, right? I think as healthcare professionals, we have to really understand that we're entrusted to do that. And I kind of liken it to being a baseball player or a football player. Let's start with baseball, right? If um if I'm a pitcher and I say, well, I can throw a fastball, a knuckleball, a curveball, a speedball. If I can get away with it, a spitball, I can throw any kind of ball you want across that plate. But I don't do a lot of fielding because that's not my job. My job is to pitch. So I might get a ground ball and throw to first, but a line drive, no, I'm gonna let that go to the shortstop. A fly ball, I'll let that go to the center fielder. Oh, and that batting thing, no, pitchers don't typically hit very well, so I don't bat. I'll get a designated hitter for that. Now, if I was coaching that guy, I would very clearly explain to him, and I'm sure any coach would, that before you're a pitcher, before you're a batter, before you're anything on this field, you're a baseball player. All aspects of baseball, you need to be able to perform. Now, you may not be winning any batting championships. You may not be winning any golden gloves for fielding, but you need to be able to at least perform, at least be proficient in getting up to the plate and doing your best to hit. You need to be at least proficient to get a ground ball and throw to first. Because guess what? When you do, that out that you created is every bit as valuable as whether it went to the shortstop, whether it went to the second baseman, whether it went to the outfielder. You need to be able to perform as a baseball player first, not just the position that you're playing. I told you I was addicted to metaphors. So how does that work for us as practitioners and clinicians, right? We need to be able to talk to our clients about suicide. We need to be able to meet people where they're at in their mind as well as their body. Look, I got clients coming in that are obese, got heart conditions, diabetes. First thing I'm talking about is how that interacts with emotional health and what it's doing for their emotional care when you're not, in fact, um, taking care of yourself medically. At Health Alliance Plan, we worked with nursing and docs to um, in uh, care teaming with them in for diabetics and for chronic healthcare crises. So in other words, we would do depression screenings with diabetic patients, and we would find that, well, when there's an anxiety disorder or when there's a depressive disorder, no wonder they're not taking their diabetic care meds and or diabetic care approaches because they're depressed or they need that aspect of it going on as well. So that's important. And as entrusted practitioners and clinicians, we need to take that whole body approach. As we move on to best practices and interventions, I've kind of separated them to two of the interventions. We'll start with interventions because obviously we need to intervene before we can get to the treatments. And the Henry Ford Zero Suicide Initiative model, and I've noted the PHQ-9 here. We'll talk about that in a moment. But Henry Ford is is amazing. I mentioned some of the brightest minds I've ever had the pleasure to work under was through Henry Ford, and what they're doing in terms of trying to eliminate suicide is truly impressive and needed and valued. And I think that um, the model of that they're using, which I seem to have misplaced. I apologize. It zero suicide model, here we go, is I promise you it's something that I've looked at, but I didn't want to try to remember word for word. The Henry Ford zero suicide model in general has found that many people who have killed themselves have gone to a healthcare professional within a year prior to the date that they killed themselves. So it's really about how patients are slipping through the gaps in the healthcare system. And despite this, healthcare has gone unchanged in many ways, and in many of these same gaps remain. But the Henry Ford suicide model is an effort then to a call to action as a systematic collaborative approach, collaborative being the key word there, to closing those gaps and to really creating a new culture of addressing and closing the healthcare gaps. And it's building a house example of tools and utilizing resources with that collaborative effort. The Henry Ford model is a three-layered approach, helping to ensure no one slips through the cracks, and that approach includes to make it okay to routinely talk about suicide screening and screening patients at all patient touch points at all the various healthcare venues they may be treating at or being evaluated at. Because regardless of what they're being evaluated for or treated for, their condition might very well be affecting their mental health. And just to demonstrate, in fact, how powerful questioning can be, Henry Ford found that asking about suicide risk is more predictive of a future suicide attempt than even cholesterol scores are for a heart attack. So also Henry Ford, and I 100% agree, notes that if, and I've thus noted it, the PHQ-9 is a proven and recommended screening tool to screen for suicide potential at all contact points in the healthcare system. So the PHQ-9 Patient Health Questionnaire 9 is a widely used 9-question screening tool for depression, assessing symptom frequency over the past 2 weeks. So and it helps to diagnose and monitor and gauge the severity, whether mild, moderate, or severe, of depressive symptoms in primary care and other settings. And it's quick, simple, and effective for tracking mood changes. So even if you don't administer it at every appointment, try to administer it at least the last question, right? And that is, have you had thoughts of wanting to harm yourself or thinking you'll be better off dead in the last couple of weeks? With regard to time, so let me run through this real quick. That another intervention is that my students had brought attention to me was the question, persuade, refer, the QPR. I would encourage that you look into that. It's again likened to CPR in that early recognition of a heart attack saves lives. So does early recognition of suicide, and it's kind of matched to it. I want to save time for questions and discussion points. So let me just quickly say that best practices, and these are all peer reviewed. My favorite and what I've used most in my practice, CBT, cognitive behavioral therapy. It's a way that goals are set. It's highly collaborative between the client and the therapist. And of course, it uses thought disruption, cognitive reframing, all the different ways that we can teach our clients to disrupt negative and inaccurate thoughts with positive, more accurate ones. So cognitive behavioral therapy is a great one. Also, dialectical behavioral therapy, better known as DBT. is it's a little different than CBT. It's a variation of it. Marshall Linehan created this some years back for borderline personality, and of course, within borderline personality, a lot of suicide attempts are made. So she built in an approach to address that, and with mindfulness and the four pillars of DBT, encourage that you take a look at that, as it also has been noted to make really significant differences in lowering the attempts and and resolving those thoughts. And then finally, motivational interviewing. You might note here that I included motivational interviewing because it's kind of the icing on the cake. I use it not so much by itself, but when I'm kind of working through with these other techniques with clients and clients become ambivalent. Motivational interviewing is great to call out the ambivalence, but it's tricky. And as therapists, I think it makes us better in that when we can practice it, because it's actually taking a step back. We don't do a lot of talking as much as we do guiding the conversation for the client to answer the questions of their own ambivalence and coming up with their uh, um, ideas about, okay, well, yeah, I could do that. Maybe I do need to do that. It was initially um, created by a couple of psychologists back in the 80s for substance abuse and substance use disorders. But since that time and in more recent times, it's been used for just a variety of different circumstances. So with that, I hope this discussion has has answered some questions, but also created some. If any questions or comments, we'll go ahead and take those at this time.
Thanks, Larry. Really appreciate that. Just a reminder for anyone, please type your questions into the chat. We'll be monitoring those and we'll throw them out to Larry as they come in.
I'm just monitoring the Q&A in the chat for you, Larry. We'll give people a couple minutes because they are typing in.
You got it. You bet.
All right, so we have, of course, people saying thank you for the informative chat. They enjoyed it. But somebody said a large part of my work is helping patients find a therapist. I'd say 7 out of 10 men request a female provider. What are your thoughts about why that is and whether men should be encouraged to try a male therapist? Which is a great question.
It is a great question indeed. I think a lot of times clients are looking for female versus male therapists for any number of reasons, right? Um, Sometimes those reasons are defensive. It's almost a reaction formation, like for men when they're thinking, well, a female therapist will be gentler, kinder. A man might judge me more for my lack of manliness or for whatever, right? Or maybe I can just control a female and I want to be able to do that because in my relationship I can't. She's controlling me, or God only knows why someone is asking for a particular gender therapist. And it can be for any number of reasons, right? But I think that sometimes, and I've got a couple of males right now. I've got one male right now that called me. He had been going to a female therapist, a psychologist for some, I don't know, 5 years, I believe. And he was in an 8 year affair, uh, extramarital affair. he called me and had met me at a father's conference that I was helping to facilitate. And I really don't to this day remember him being there, but he called and said, I need a male therapist. I want to talk to you. And he was suicidal at the time. He's doing phenomenal today. I'm thankful to say. But when I asked him why, he said, well, I've reached a point with this therapist that I think she's just too nurturing, taking care of me, and I need to question my manhood. I need a man to help me to do it. I said, what does that mean? What do you mean question your manhood? What are you saying? Does that mean? And he's like, well, why I did what I did, and what does it mean to be a man, and what does it mean, all the things that male to male is going to be uh, able to be better answered. I don't mean to offend anybody if you disagree with this, but look, I think that there's some realms that it's a man needs a man to be able to teach maleness, and a female needs a female to teach what femininity. I think I'm a pretty good therapist. I'm pretty experienced. I'll be the first to tell you that I don't know anything much about being a woman. I'll be the first to tell you that. I know what I know and what women have told me, but I think that there's when therapy reaches that point, and it can, a female therapist can be very helpful. I don't want to generalize, but I do think that oftentimes in therapy, these are the kinds of things that come up. And it's at that point that you want to do that. So I think it's understanding why the clients that's requesting a female or male therapist is requesting it. And that's kind of what you want to kind of talk about and get to know and get to understand first. I hope that answered the question. Let me know if not. Welcome.
All right. Thank you. That was a good answer. We did get an answer in that asked about any suggestions if someone is on the phone with a patient in crisis, and that they do give the suicide prevention crisis number, but wanted to see if there's any suggestions you have, probably especially for male patients. Now, I didn't know if you'd get to it, Larry, so I did put in the chat. Very important to ask about access to lethal means, if there's supportive people there with them or nearby, and if they have any plan or intent to hurt or kill themselves or anyone else. Is there
Yes.
any other suggestions besides giving like those 988 numbers that you would suggest for that person?
I would suggest a connection to the client, to let them know, look, I really appreciate validating them. For example, validation is so huge. It's a human need for real. And validating, I do this with my clients too, that look, I'm really, really glad that you brought this up. It shows just how resourceful you are, how wise you are to do so. And so after you make that call, or after you get to where we agree that you're going, let me know. Tell me what's going on, because then it's in their mind, right? It's like, okay, they're with me. They're, even if I'm not physically there with them to hold their hand to it, right? It's kind of like that feeling that they are. And uh, that can be very, very helpful in keeping the client motivated to follow through with what you've agreed, to follow through on.
Thank you. There's a couple more questions in the chat, but I know we're about at time, so I'll let Jason wrap us up here. And we'll keep the questions that you guys have in mind as we present things through our My Mind Collaborative as well.
Awesome. Well, thank you so much, Larry. I just wanted to note that Larry also included references as well to his presentation today, which are included. So we will share these out with everyone who was in attendance today, so you can have the presentation as well as those references. Just a huge thank you to Larry for such an engaging and informative presentation today. We really, really appreciate you joining us. I, for one, learned so many things, not just about you, but about men and masculinity. And being a man myself, that's says something. So thank you very much, Larry, for everything that you shared today. Before we wrap up, just a quick reminder about the CME CEU credits. In order to receive credit for today's session, please text the code on the screen to the phone number provided. Again, you will have 24 hours to claim your credit. We also included a how-to sheet for those of you that received the meeting invite. If you're having any trouble with that, please email the My Mind Coordinating Center and we can assist you in making sure you get credit for today's session. On behalf of the entire My Mind team, thank you again, Larry, for sharing your expertise, and thank you
My
to
pleasure.
everyone who joined us today. Please note again that the recording and presentation will be distributed via email to all attendees within 1 to 2 business days. And finally, your participation certificates will also be emailed to you in the next few days as well. Once again, we thank everybody for joining us today, and we will see you next time for our On My Mind webinar series on April 23rd with Dr. Anthony Ruffy, who will be presenting on sleep and suicide. We'll see you then. Thank you.
Be well.